the patient was
at rest. So the only way to increase oxygen supply to the heart muscle has to be through an increase in flow. There's a direct correlation between oxygen delivery and flow. And so there is a wider variation in flow within the heart muscle than there is anywhere else in the body. And so for you not to be ischemic, you really need to be able to augment your coronary flow by at least 2.5. And so a CFR, which is a ratio of maximal flow to resting flow, that ratio should be normally greater than 2.5. And honestly, in most normal people, it's like 3 to 4 or even higher sometimes. You know, like a young person, athletic, probably has a CFR of like 4. But if you have a blunted CFR, your coronary flow can only augment by, say, 2-fold or less, then this is where you start to have ischemia. And, you know, if you think about like these nuclear tests, I don't know if any of you ever look at nuclear imaging. This is actually a picture of a black hole, but I thought it was it looks like a nuclear stress test, so I love it. It ended up in my slide presentation, and I've left it there. But, you know, when you see a nuclear stress test and you see something like this, this would be like the equivalent of the cross section of a left ventricle. You know, we would show that to patients and we'd say, oh, you see the left side is not getting as much blood flow as the right side. But actually, if you really wanted to be accurate, what you would say is that the left side is not augmenting its flow as much as the right side, because that's what a nuclear stress test really does, right? You give adenosine or you have the patient exercise, and you're really seeing what happens to flow during exercise, during stress. And it's not that you get a decrease in flow, but rather you don't get as much of an increase as you do on the other side. So you're actually measuring CFR when you do a nuclear stress test. And a lot of people don't realize that. The fact that CFR is important is clear. Every study that looks at the prognostic implication of a low CFR has shown that it definitely is bad. But this is where it helps us, is that as we think about the epicardial coronary arteries and the microvessels, the CFR is affected by both. It's kind of like a global sense of ischemia. So if you have a situation where you've ruled out epicardial coronary disease, let's say you've done a cath and they're epicardial, you see no blockages, they have so-called clean coronaries. If you measure the CFR and you find that it's low, indicating that they have ischemia, then you know it's got to be the microvascular bed. So this has been sort of the crux for how we're diagnosing microvascular dysfunction now. It's through this impact it has on CFR. And I said there hasn't been traditionally any easy way to measure any of this. You really need to be able to measure flow, right? If you have a way of measuring flow in a coronary artery, then you've got everything you need, because you can measure flow at rest, you can measure flow during stress, and you can just simply calculate that ratio I mentioned. And it turns out that, for those of you who remember Ohm's law, that if you know pressure in the vessel, which for decades, we've had these pressure wires that we routinely put in the coronary arteries, so we can measure pressure. If you have pressure and you now have flow with this newer technology, you can calculate resistance. And that's for a lot of people is an easier way to think of microvascular dysfunction. That is, people where the microvascular resistance is elevated. And this term is IMR, and you'll start seeing this in cath reports. So in cath reports that look at this, they'll mention CFR and they'll mention IMR. So how do we do this? How do we measure both pressure and flow? So there are two different types of technology. There's the Doppler wire that has been around for a little while, but it's kind of clunky. It's been mostly reserved for research studies. But what has really been revolutionary is this new temperature wire, where you slide this. So this wire has a couple of temperature sensors. This is a coronary wire. So even though it looks big here, it's like a hair. It's a coronary wire. So you thread it into the coronary artery, and then you do a cold saline injection. So we're talking like 3 cc's. You do a rapid injection of cold saline into the coronary, and you get these temperature curves like you see here at the bottom. And this fancy software can calculate the mean transit time, and based on that, can actually calculate flow in the coronary artery. And it's fairly reproducible. So if you, and remember, what we're interested in is the ratio of flow. So you actually don't need to know the absolute flow. You just need to be able to have a reliable way of comparing flow in two different states. And if you do that, then you can calculate CFR and IMR as shown here. This is what the screen for this device spits out. And you have transit times at rest, you have transit times during hyperemia, which is induced with adenosine. And so you get the CFR and IMR, and just so you know the normal range again, CFR would be abnormal if it's less than 2.5. That is, if you can't augment your coronary flow by at least 2.5. And then the IMR, which is resistance, if it's greater than 25, then that's abnormal. So this was actually the first patient that I did several years ago. And this was a woman who had been to the cath lab 4 times within 10 years, every time being told your arteries are fine, there must be something else going on. And she was really distraught with all this, felt like everybody thought she was crazy. And so after we did this, at the end of the procedure, I told her, you've got coronary microvascular dysfunction. This is why you're having symptoms. This is why everyone keeps thinking that you've got angina and you keep ending up in the cath lab, but we now know why. And she started crying. So this is my first case, and she's bawling on the table because she just felt like, wow, so you actually know what's going on, and I'm not crazy. And that had a big impact on me, certainly as a practitioner. So here's an example of a case. So this is a gentleman who had classic angina, the typical, I'm moving my trash can up and down the driveway and I get this chest pain. So he gets cathed and tight blockage, right? So this is, anyone can see this. Oh, so he's got epicardial coronary disease. So he undergoes a stent placement, and this is done by one of my partners, and gets an awesome result, right? Beautiful stent. So everyone's high-fiving each other thinking, we did a great job. But he calls the clinic in a couple of weeks and says, I'm still having chest pain. Like, I can't do anything. And so the initial thought was, oh, there must be something wrong with the stent, or maybe we missed something, et cetera. So bring him back to the cath lab. Stent looks great. We don't see any other blockages anywhere else. So what's going on here? So he actually ended up on my schedule for this. And so naturally, I proceeded to check for CMD, and he had very abnormal numbers here. His CFR was 1.6, his IMR is 42. So these are, again, very abnormal. And so this is a case, very instructive case of where, yes, he did have epicardial coronary disease, but the stent was treating the wrong problem. The real problem in this person's case was CMD, microvascular dysfunction. So what else? So we've talked about CMD. What else can cause ANOCA or MINOCA? And coronary vasospasm is the other big entity that you should all know about. This was one of those things where I remember in training, we thought, oh, this may not be a real diagnosis. It's in the textbooks. We learn about it in lectures, but it's not a real thing. We never see it. So what is coronary vasospasm? So this is where you get intense vasoconstriction of the coronary arteries. It causes sudden ischemia. And the thing about vasospasm is that it feels like angina, but the pattern is completely different from epicardial coronary disease or CMD, in that instead of usually being exertional angina, this is random. It's non-exertional. It's frequently at night. Patients will say, oh, I wake up in the middle of the night with this, or it's in the early morning. It's self-limited usually. It usually lasts anywhere from 5 to 15 minutes and will go away on its own. And most patients will say that when I take sublingual nitroglycerin, it goes away. And these are the patients who have especially been ignored because, historically we say this is atypical angina, and it's probably non-cardiac. And there are so many of these patients out there, right? These patients tend to be younger. It's a little more common in men, but we don't know whether that's really true or not, because in some studies it looks like it's about equal between men and women. Risk factors, smoking is a big one. And then interestingly, there is this association with migraines and asthma. If you think about it, in both those conditions, you've got sort of hyperreactive smooth muscle layers in these different conduits. And so there may be sort of a common pathophysiology. And importantly, in these patients, they all get a stress test, and their stress tests are normal. So not only are their symptoms atypical, but they have a normal stress test. So you don't need to see a cardiologist. You don't need any further cardiac testing. Your symptoms are non-cardiac. And that's what happens to these patients. So how do we test for it now? So now we do acetylcholine testing. So if you look here's a normal angiogram, and here's after acetylcholine. And if you just compare, go left and right, you can see like the LAD, left anterior descending coronary artery, which goes down the front of the heart, it basically almost completely disappears, as does this diagonal branch. And so you know, the normal response to acetylcholine is that it's a vasodilator. So when you see this paradoxical response, then that is fairly diagnostic of coronary vasospasm. So here's an instructive case. This was a gentleman that one of my partners saw who's having multiple episodes of chest pain daily, ended up in the cath lab, and he has this diffuse LAD disease here. And using due diligence, my partner put a pressure wire into this vessel to see if this is obstructive disease, and it was obstructive. We use this thing called FFR. It's 0.74. Cutoff is less than 0.8. So my partner went ahead and placed a stent using state-of-the-art techniques, using intravascular ultrasound, et cetera, and got a beautiful result, and told the patient, you're going to feel great. But his symptoms didn't improve at all. He continued to have chest pain. So he was sent to me, and I decided to do some additional testing. I tested him for CMD. That testing was normal. But then I did acetylcholine testing, and you can see here the LAD, which runs down here, essentially disappears. His circumflex, which goes like this, actually completely occludes with acetylcholine. So his symptoms, which honestly, in hearing the quality of his symptoms, it did sound more like vasospasm. He was having a lot of episodes at rest, intense squeezing in his chest, and then it would resolve in about 15 minutes or so. It was a pretty good story for vasospasm. So he had never been on a calcium channel blocker, which is sort of first line therapy, because he'd always been treated with ACE inhibitors and beta blockers, as you would do for coronary disease. And simply switching him away from the beta blocker, which can aggravate vasospasm, to a calcium channel blocker, his symptoms melted away, and he's doing much better. So, to those who would say, oh, this is all esoteric coronary disease, how common is CMD and vasospasm? So this is from the Cormica trial, which I'll show you more about later. They basically took consecutive patients who were referred for an angiogram for chest pain, and they found, consistent with prior data, that about half of them had obstructive disease and half of them did not. They took the patients without obstructive disease, and they tested them for all of these things. And remarkable, and this has been reproduced by several other groups, where if you take these patients without obstructive coronary disease, about 2/3 of them have CMD. So that's blue plus this red. About 1/3 of them had vasospasm, and a small minority had normal testing and were actually deemed to have truly non-cardiac chest pain. And you can see it's only 11%. So most of these patients who reach the point of reaching the cath lab, being referred to the cath lab, the likelihood of having some abnormality is very high. And if they don't have obstructive coronary disease, it's probably CMD and or vasospasm with some overlap. You can see this red area here, a lot of overlap. So as you think about the coronary arteries and causes of angina, traditionally we think of just the epicardial coronary arteries, and we think of fixed blockages caused by atherosclerotic plaque. But we now know that the microvascular bed is just as important, and that can cause angina due to blockages in the microvessels. But now we also know that coronary vasospasm is an important player. You can have vasospasm, in fact, in the epicardial arteries, but you can also have it in the microvascular vessels. And these entities here in red are what constitute ANOCA. And it turns out that there are multiple so-called endotypes where you can get combinations, different combinations of these various entities. There does tend to be a lot of overlap, just like I said, how people with coronary disease can also have CMD. And I showed you a couple of cases where that was true. So should we be testing for all of this, right? This all sounds kind of mad scientist type of testing. And it's being embraced by all the expert committees. So this is the European Society of Cardiology, their official guidelines published less than a year ago. And they now give it a class 1 indication. So class 1 meaning they recommend it full-heartedly. They think there's enough data to support it, and they think it should be standard of care in patients who are persistently symptomatic and suspected to have ANOCA. So most of these patients have already had a cath before that didn't show any blockage, or maybe they had a coronary CTA. We're seeing a lot of these. I'm seeing a lot of these as well, patients who get a coronary CTA, but there are no blockages, but they're still having anginal type symptoms. And those patients do get referred for ANOCA testing. And if you look at the American College of Cardiology, American Heart Association, so their latest iteration of the guidelines is in 2021. So they're due up for one in the next couple of years. Back then, they gave it a 2A recommendation, which means they recommended, but they acknowledged that maybe there wasn't quite as much data as they would like. But 2A is pretty good. And the expectation is that in this next iteration, they'll probably give it a class 1 recommendation. So one of the landmark studies for all this is the CORE-MICA trial. I referred to it briefly earlier. So this is the one where they took patients who came in consecutively to the cath lab for chest pain, and they took the patients who didn't have obstructive coronary disease, and they did this testing, right? All this microvascular testing, vasospasm testing, and all of them. But they randomized them to either being provided with the results or not. And they call that the sham group. But the group that was given the information, the providers were also given a protocol for how to treat the ANOCA. So they categorized them as microvascular angina, vasospastic angina, and then of course non-cardiac. And if it was non-cardiac, meaning that all their testing was normal, they simply stopped all cardiac medications and said, go look for something else. And they were as specific as this. If they diagnosed microvascular angina, they would tell you what first line, second line, third line therapy is. Likewise with vasospastic angina, et cetera. And what they found is that there was a marked improvement in symptom score in the patients who were provided with the results. This is the Seattle Angina Questionnaire, where they started at a baseline of about 50, which is kind of like mild to moderate angina. And by the end, a lot of them actually had no angina, whereas the control arm, they kind of stayed flat. And one of the important things about this study, we hear a lot, people say, well, why do all this testing when you can just simply cycle through the meds, treat them empirically? The reality is that those patients get lost. Like, yeah, you tweak a little medicine, but then, a year later, they're still on the same medication, they're still having symptoms. And furthermore, if you have a diagnosis, you're much more willing to push medicines a little bit further in the proper direction. So for example, patients with vasospasm, right? I said calcium channel blockers are the first line treatment. A lot of patients I take care of with coronary vasospasm end up on both verapamil and amlodipine, which, before the age of coronary vasospasm, you'd say, oh, you'd lose style points for that, because why would you put someone on 2 calcium channel blockers? Well, it turns out a lot of these patients do improve once they're on both of those calcium channel blockers. So you would only have the courage to do that, though, if you knew that the patient really had vasospasm. So there's a lot of value to this testing. So what else? I can't leave without talking about myocardial bridges, which is my favorite topic. So as you know, the coronary arteries, they tend to run along the outside of the heart as the heart is doing its pumping. So they kind of ride along the surface of the myocardium. But some people are born with a situation where you have a band of heart muscle tissue that goes over the coronary artery. So this is the left anterior descending here. Or another way to think of it is it's sort of like a pipe that goes underground and then reemerges downstream. And the consequence of this is that during systole, the vessel gets compressed, but it turns out more importantly, during diastole, there's less compliance to the vessel. And so angiographically, this is what a myocardial bridge looks like on the left. You can see that the left anterior descending there getting totally squashed during systole. So it's like systole, systole, systole. And again, it's because the vessel is embedded in the myocardium. And it turns out a coronary CTA shows this perfectly. So here's a coronary CTA, the LAD dives into the heart muscle, and you can see this band of heart muscle tissue going over the LAD. And interestingly, this has been visible on CTAs for as long as coronary CTAs have been around, but the radiologists or cardiologists who report these have not been mentioning bridges. You just won't see that mentioned in the findings or in the conclusions. So I've asked our radiologist about a year ago to look for bridges and to mention in the report. And so for those of you ordering coronary CTAs, you will start seeing this popping up in reports, which is good and bad because one, it helps identify whether there might be a myocardial bridge contributing to their chest pains. But if you remember that like a third of people on postmortem studies have a myocardial bridge, you're gonna get a lot of these sort of like incidental findings, right? And we get a lot of calls of, panicked patients or providers saying, "Whoa, what do we do with this result?" So, but in any case, just keep in mind that you'll be seeing more of this on reports. So here's a case that took care of recently. So this was a gentleman, truck driver, who's having a lot of angina, had an angiogram done years ago, and had left main disease, had diffuse LAD disease. You can clearly see there's a lot of coronary calcification. And so for this disease, bypass surgery certainly made sense. So he underwent bypass surgery, but he didn't feel any better. So he had his bypass in 2018, all successful, no complications from it. He was still having angina. He didn't feel any better. And subsequent to that, because he was still complaining of chest pains, he underwent all kinds of stenting. He had his left main stented, even though that was the main reason for his bypass, and his bypasses were looking good. They still stented his left main. They ended up stenting a vein graft for some plaque that was there. They ended up stenting his mid LADs. So this guy was subjected to a lot of procedures, and none of this made him feel better. And he had a total of 6 stress tests that I could count over a period of a decade. So this guy was really put through the mill, not feeling any better, very frustrated. So he was sent to me, and so I was doing my usual sort of thorough, comprehensive examination and testing. And I thought, it kind of looks like there's a bridge here. This is an injection through the left internal mammary artery graft into the LAD. And I thought, this kind of has the look of a bridge. So it's hard to tell angiographically sometimes if there really is a bridge. And so I went ahead and put an ultrasound catheter into the vessel. So this is going to be a pullback video. This is starting distal. So these pullbacks, you start distal, and then the catheter gets gradually pulled back to the proximal vessel. And so downstream of this area of interest, the vessel looks completely normal. This is what a normal coronary artery looks like on IVUS or intravascular ultrasound. You have this dark layer, that's the media. This is all the lumen here. And this white stuff out here is the adventitia. And usually the vessel is surrounded by that white adventitia. Oops. See. All right, so here's the pullback starting. And now you see this big black band along the top, and you see the vessel getting squashed. It gets turned into an oval. And this is a massive myocardial bridge right here, several millimeters thick. And we were able to take measurements and all that. So now the question is, oh, well, maybe this is the cause of his angina. Oops. How to go forward here. Next. So coronary CTA, which again is really good at delineating bridges, and it confirms the presence of a bridge exactly where we saw it on the intravascular ultrasound. And to prove that this actually is hemodynamically significant, we put a pressure wire into that LAD, into the distal vessel. And this is just, it's called RFR. It's basically a way of measuring pressure gradients across stenoses. And his was very abnormal. 0.68 is very abnormal. So this appeared to be hemodynamically significant. So he went to the operating room, had a surgical unroofing, which is where you basically it's like digging up a pipe that's underground and releasing it from the myocardium. And for the first time in 8 years, totally angina free, completely. So this was a incredible case that really shows how, the presence of coronary disease, we're so stuck in that in treating epicardial coronary disease that we always chase that first, but there may be one of these other things going on at the same time. So here at Providence, we do comprehensive ANOCA testing. We're actually the only place in the entire state that does it. And it's a protocol where we test for everything, even if we're suspecting just CMD or if we're suspecting vasospasm or just a bridge, we test for all three. And that's because a lot of times these things overlap, and it's important to understand what's going on in a comprehensive fashion so that when we treat, we can treat all of the things that are causing problems. So what we do is we first test for vasospasm. So it's just like a regular cath. You bring the patient in, you hold their vasodilators. We usually use radial access. It turns out that's okay for most patients. And then we'll inject acetylcholine into the coronary arteries. We do angiography looking for spasm. At the end of that phase, we then reverse the nitroglycerin. And then we put our pressure and flow wire into the coronary artery, and we do flow measurements. And from that, we calculate the CFR and the IMR, and this is to see if there's microvascular dysfunction. And then the third phase of this testing is to look for a myocardial bridge. Now, if these patients already had a coronary CTA that showed no bridge, then we obviously don't do this. But otherwise, we'll put an ultrasound catheter into the LAD because that's the most important vessel in terms of bridging. And if we do see a substantial bridge, then we do physiology, where we give dobutamine and we measure the pressure gradients across the bridge. And there are criteria for what's considered hemodynamically significant for a myocardial bridge. And getting back to this point I made about how a lot of these things overlap, the common thread is this idea of endothelial dysfunction, that when you have a condition that predisposes to abnormalities in the endothelium, that can predispose to microvascular dysfunction as well as spasm. And this was a really interesting study, and this has been shown by a couple of groups, where the presence of myocardial bridge tends to promote endothelial dysfunction. So this group took patients who were referred for surgical unroofing for myocardial bridge, and they tested them doing adenosine testing, which is for microvascular dysfunction, acetylcholine testing for vasospasm, and they found really high prevalences of these conditions. I mean, 60% of patients with a significant myocardial bridge also had CMD, and you see here like 30 to 40% of patients with myocardial bridges also had vasospasm. And this is consistent with what I'm seeing in my practice. When someone appears to have a significant myocardial bridge, they almost always have one of these other things going on. So this underlines the importance of testing for all of this. Because, for example, if someone has a bridge and they have vasospasm, well, our first line of treatment will be to treat the vasospasm to see if that alleviates the symptoms, because you don't want to be sending somebody for open heart surgery if you don't need to. So in terms of treatment, there's been some great reviews recently. This one came out this year in the JSCAI journal, and they have this beautiful graphic here. I actually copy and paste this into all of my reports. So here you're testing for vasospasm, CMD, and myocardial bridging, and it lists the criteria here, and they color code it so you can quickly come over here and find the color you're looking at. If it's just CMD, or if it's the combination of CMD and myocardial bridging, or if it's myocardial bridging and vasospasm, every combination you can think of, it tells you sort of what's first line therapy, second line, what might be helpful, and what probably won't be helpful. And as you think about this, so this is a graphic from a different review article that came out a couple of years ago in the Journal of the American College of Cardiology, which is a fantastic article. And if you look at all these different entities, one of the common things that is recommended across the board is, statins, exercise, weight loss, et cetera. And this is getting back at that common pathway of the endothelial dysfunction. If you can improve the endothelium, perhaps all of these conditions will improve. But some important principles that if there's spasm, for example, you want to avoid beta blockers. Beta blockers can worsen spasm. Whereas in things like CMD or myocardial bridging, beta blockers can be good. And then finally, myocardial bridging is unique in that it's the only one of these entities where there's potentially a surgical option. So in conclusion, angina can occur without obstructive coronary disease. These conditions are common, they're important. We can test for it now, and establishing the diagnosis does lead to improved treatment. And I'll stop there.
Wow, Dr. Stone, thank you for so much clarity on what has often been a confusing topic for many of us. That said, I'm sure we have some additional questions. Anyone in the room want to get us started?
That was beautifully done, and your expertise is quite impressive, obviously. I'm infectious disease, so if I say something stupid, feel free to call me out on it. When the pathologists look at those small vessels, is there any abnormal histopathology?
Yeah, it's a good question. So certainly with CMD, there can be for sure. I mean, there's a wide variety of causes for CMD, microvascular dysfunction, and so there's a whole range of abnormalities they can see. It depends on what the pathophysiology is. For vasospasm, not so much. And oftentimes these patients will have actually completely normal coronary arteries, and we'll see that when we do the intravascular ultrasound or the coronary CTA. I can't say that there are specifically post-mortem exams of people with coronary vasospasm. So actually, I'm just speaking sort of conjecturally. And then, of course, myocardial bridges, that's something that has been ignored. It's not mentioned. I've never seen that mentioned in a pathology report, and I don't know of any post-mortem studies looking at that. So, this is an example of how we're constantly learning in this area. It's relatively new. I mean, even, I'm telling you about it, but even within the world of cardiology, there's still a lot of cardiologists who aren't thinking about these things. I've sort of beaten my colleagues over the head enough with this that they are thinking about it. But even then, I get referred patients for caths, and I think, oh, they should have been thinking about ANOCA for this patient. So there's a lot of education that's needed out there.
This is a game changer in a lot of different ways. From a primary care perspective, I'm wondering about how to filter patients and what the risk is here of spectrum. When you see a patient as they walk into your office, the pretest probability that they have some symptom related to their heart is going to be much, much higher than someone that I am seeing who has chest pain. And as you inform us of the possibility of this testing, or put it otherwise, advertise the availability of this testing, I'm concerned that you're going to get a spectrum of patients who just don't have heart disease. And it seems like the fulcrum might be the definition of angina, which I've always felt cardiologists are much better at identifying yes or no. Maybe you could help us with that.
Yeah, that's a great question. So I guess as I think about patients who come to us or patients that you see, I sort of think of three different categories. So you have the patients who fit into that, atypical chest pains, normal stress tests. So I'm not going to bother the cardiologist with this, and we'll just keep looking for what else this might be. And I think that a change in practice would be to say, well, maybe it is anginal. And, what I see in a lot of charts is people will say, classic anginal chest pain, but it's non-exertional. And I've seen that in a lot of charts. And that right there is a red flag. That's like, oh, you should be thinking about vasospasm. If you're thinking that the symptoms sound anginal, and I've seen this, and I'm talking about not cardiologists, but primary care or even the ER docs, et cetera. The second group is the patient that's been deflected back to you from the cardiologist because they have gone through the mill of testing without thinking of ANOCA, and they just say, nope, arteries are fine, follow up with their primary. And there are a lot of those patients floating around out there that are in your practice. And so I think the awareness of this might make you think, oh, well, maybe I should send them back to the cardiologist because maybe they have one of these entities. The third group that kind of to your point, I'm getting a lot of patients who clearly have symptoms that don't sound like angina, but they're referred to me for this testing. And that's in part because of frustration. Like these patients, they keep having these chest symptoms and they're not getting better no matter what we do. So let's send them for this ANOCA testing. And I do get some of these. I tend not to turn down this testing. I mean, the reality is it's actually pretty safe. And by the time these patients get to me, they're like determined to have this testing done. They've always done all the research into this. And so that's something we're trying to figure out. I mean, I do think there are patients where you can tell without this testing that this is non-cardiac symptom. So anyway, it's evolving. I mean, I'm definitely seeing a surge in referrals, and just trying to figure out how to best navigate that.
Thanks, Dr. Sound. That definitely helps. Just to press back on the question a little bit, in your experience, are there features that you are seeing that are so suggestive of angina? Like, we all learn this in medical school, we work on it through our careers, but are there things you're seeing that people could be doing better in terms of their history to discern angina?
Yeah, that's hard. So I used to say that, it has to be exertional if it's going to be anginal. But of course now, as you've heard, I mean, it's that whole idea has been questioned, and a lot of it is the quality of the symptoms, but that's hard too, because as we all know, there are patients who have sharp stabbing pain that's actually a manifestation of exertion of angina, or shortness of breath that's a manifestation. So I would say there are no hard and fast rules. But if someone tells you, I get this squeezing in my chest, radiates to my neck or my arm, I don't care if it's with exertion, without exertion, I think you have to think that it's angina.
Thank you.
I think let's take this question back there.
I just have a question about the vasospastic angina, and talking about the acetylcholine testing kind of being the gold standard for diagnosing, but I'm just curious, kind of prior to that testing, when you're doing the initial cath, are there any clues that are kind of cueing you into that it might be vasospastic based on just the initial cath findings? Like, I have like vague memories of myocardial dilatation, them talking about like kind of exaggerated reactivity of the coronary vessels in response to just insertion of the cath and dye, and kind of normal contour of the arteries, but they just appear narrowed.
Yeah, it's a good question. So we occasionally will get patients where you go in for the angiogram and you see spasm like right at the ostium of the coronary artery, right where the catheter is. And so we sort of consider that, catheter-induced spasm. Whether that is indicative of underlying coronary vasospasm is not clear, and there's a lot of debate about that. I think most of us think that in itself is not a specific enough finding. But on the other hand, if you see spasm downstream where the catheter is nowhere near it, I definitely have had patients where you do the angiogram and you see a whole bunch of spasm downstream. I think that's probably the real thing. What has changed, though, in the last 5 to 10 years is that, you may know, we're now doing all our casts through the radial artery. We used to go femoral, right? And when we go radial, as soon as we get that sheath in, we inject verapamil to reduce radial artery spasm. And of course, that would tend to alleviate any spasm you might see in the coronary arteries. So I think it's become a lot less common to kind of see that spasm at baseline in a regular angiogram, in part because we're treating it already with verapamil. Some people give verapamil and nitroglycerin. So unlikely to see it. And so you have a question here.
The patient who queried me had a calcium score, dystrophic calcification of the coronary arteries. And is that fit into the differential, or is that an entirely separate entity?
Yeah, that's a whole lecture in itself. And I think I'm going to steer clear of that one, the coronary calcium score. That's beyond the scope of what I think I can say at this point.
Dr. Sohn, I have a question about the COMICA trial, which seems like a landmark trial behind motivating us to test patients and treat patients for these. Was there all-cause mortality data on that? Because all of this testing is going to be very expensive for the health system. And does it help patients live longer, or it just help patients reduce symptoms with all the testing and treatment?
Yeah, there's no survival data with any of this, nor is there the expectation that this treatment would necessarily result in a survival benefit, certainly within a short period of time of a few years. Again, this is a relatively young field, but the focus really has been on symptoms. So it's really about angina control.
You showed some data that patients with, I think it was bridging, seem to have a high incidence of microvascular disease. It's not intuitively obvious to me why any of those three categories should overlap, vasospasm, microvascular disease, and bridging. If it is to you, could you explain how, or are you really just seeing the underlying rate of microvascular disease that has nothing to do with the bridging?
Yeah, so that's a good question. So So with myocardial bridging, we know that, for example, there is increased likelihood of atherosclerosis in the vessel, and it tends to cluster around sort of proximal to where the bridge is. Likewise, when we see vasospasm, it tends to happen within the bridge segment or adjacent to it. This is something that I see all the time. And so the assumption is that endothelial dysfunction, which, by the way, is actually part of the acetylcholine testing. There's criteria for diagnosing endothelial dysfunction. That seems to be the precursor to all of that. So the thinking is that the presence of the bridge, because of the impact, the effect, the mechanical effects it has, the flow effects it has on the endothelium, it generates a situation where you have endothelial dysfunction, which then predisposes to atherosclerosis and predisposes to CMD and vasospasm. Now, I guess in all fairness, if you took totally normal people, because you might think that these patients with myocardial bridges, if that's their only problem, they should test similarly to normal people in terms of these other things, right? So there is not a study where they've taken a number of like normal people and tested them for CMD and vasospasm. So I suppose it's possible if you did that, maybe you'd find 60% of people have CMD, but I think you won't. Sorry, CMD is coronary microvascular dysfunction.
We have more choices than ever for stress testing in the primary care setting, including increasing use of coronary CT with fractional flow reserve. Can you comment on among those, which has the least concern for false negative for ANOCA? So if we're worried about that, are some tests better than others to try to ultimately perhaps get them to the cardiologist?
Yeah, so I'll start with vasospasm, for which none of that testing is useful. You'll get a negative stress test in all those patients. Coronary CTA is not helpful. For myocardial bridging, the CTA will show it, whether you have it or not. And actually, a lot of literature has looked at stress echocardiogram because you tend to see this weird like hinge motion of the distal septum in those patients. And a lot of the patients I've taken care of who have significant myocardial bridges, they'll have a prior echocardiogram, like a dobutamine echo or a treadmill echo, and they'll have this apical septal abnormality. So it's a little better for that. For CMD, any of the stress testing should be just as good as it would be for epicardial disease. And in fact, there's been the suggestion that all of these so-called false positive treadmill stress tests where you see these ST segment changes, it has been suggested that those patients may actually have CMD. Because a lot of those patients end up going to the cath lab and have normal coronaries, but perhaps they all have CMD. That hasn't really been fleshed out yet in studies, but that's a really interesting idea.
Great. Well, I think we're probably perfectly coming to the top of the hour. Thank you for so much opportunity for questions, Dr. Sohn.
Thanks for having me.